All right, is everyone ready to get going? All right, I have some opening remarks. It's great to see all of you. And I'm just going to introduce and kick off tonight. This is a fun night for our seniors who are going to be here, and hopefully all of you, the rest of you underclassmen, will get to see kind of what you get to do once you become a senior and all of that fun stuff. It's good to be here in person with everyone again this year, so it's nice to see everyone. I'm just going to kind of introduce today, and then I'm going to kick it off to a video, and then Dr. Lewis is going to introduce our seniors and our capstones, okay? All right, well, first and foremost, good afternoon, students, faculty, staff, and any guests that are attending, and welcome to our 2022 Exercise Science Senior Symposium. Today we celebrate all of the hard work, dedication, and accomplishments of our seniors, as well as we're going to recap our 2021-2022 academic year. I know I speak on behalf of all the exercise science faculty when I say just how proud we are of our graduating seniors that are sitting up here right now. This class came in the fall of 2018 and had to adapt to all of the challenges the pandemic threw at them, starting as sophomores and juniors, which are some of the toughest academic years. If all of you know who are those of you who are juniors can probably attest to that right now, right? Some of the toughest academic years. So all of our exercise science students not only rose to the challenge, but they also adapted, overcame, and surpassed any academic expectation we threw at them. I've watched these four grow over the past 4 years, and I could not be more proud of the young professionals they are becoming. I'm sad to have missed most of your senior spring being on maternity leave, but I'm thrilled to be here with everyone tonight. The division also would like to welcome 2 new full-time faculty members, Dr. Catherine Lewis and Dr. Christopher Swart. We are very lucky to have their knowledge and enthusiasm for the exercise science field translate to the classroom with our students here at AIC. All of you probably know who have Dr. Lewis, Dr. Swart, and so forth as new faculty members can probably see how much they really enjoy being here, which is great. Today we are excited to watch our seniors present their capstone projects as their culminating academic experience. We have a wonderful program set for you today, and we will first begin with a video to recap the year, and I want to thank Dr. Swart for doing that. From there, we will welcome our seniors, announce our Exercise Science Award, and begin our capstone presentation. So here, to kick it off, we are going to start with our Exercise Science video.
Let's go.
$42.
All right, so we are going to welcome our seniors in just a minute, but first I would like to welcome Dr. Catherine Lewis to present our Exercise Science Academic Award, our senior award today, as well as then start introducing our seniors. So with that being said, welcome Dr. Lewis.
Hi guys. Okay, so the Exercise Science Excellent Award is given to the graduating senior with the highest GPA and who has exemplified academic excellence within the undergraduate exercise science program. This year's recipient is Christopher Manginelli. So, come on up. So Chris not only shines academically, he has also been highly active with multiple extracurricular activities throughout his time at AIC. Chris has been a varsity football player for AIC for the past 4 years, an academic tutor for the biology and exercise science department, a leader of the exercise science club, an exercise science student mentor, and a student ambassador for the Exercises Medicine on-campus program. Chris, please accept a certificate of recognition and know that your hard work and dedication to your studies have been exemplary. We in the Exercise Science Division are proud of your accomplishments, and we know you will continue to shine bright in your future endeavors. The faculty and I wish you continued success. Okay, all right. Yeah, because I still have to introduce you anyway. All right, so with that, Chris is also our first presenter, so I'd like to introduce Christopher Manginelli, who's here to present on the impact of blood flow restriction training on fitness parameters in sedentary individuals. All you, Chris.
All right. First off, do you guys have any idea how hard those pistol squats are? Like, come on. All right, I'm presenting on the impact of blood flow restriction training on fitness parameters in sedentary individuals. So just a brief outline of what we're going to be doing today. We're going to talk about the background and history of BFR, some of the safety behind it, physiology, fiber types and adaptations, the practical importance. So we're going to talk about sedentary populations. We're going to go into resting metabolic rate, body composition, aerobic capacity, and finally the research proposal. So a bit of a background on blood flow restriction training. So BFR is the process of using a device to limit some of the arterial flow to skeletal muscle during exercise and restrict venous return. So what we're doing is we're altering our hemodynamics and changing the way blood is flowing during exercise to induce metabolic adaptations. So we are going to take a blood pressure cuff and apply it to the proximal portion, the portion closer to your midline, and reduce blood flow, which will stimulate muscular adaptations. So some of the background and history of BFR. So Yoshiaka Saito in the 1960s developed the original BFR training. It was originally, in Japan, it's known as Katsu, which translates to pressure training. And in the 60s, Dr. Saito was kneeling and felt a weird feeling in his lower legs because he was kneeling for so long, and he was actually occluding some of the blood flow to his lower extremities, and he noted it felt like he just did a heavy squat workout afterwards. So upon further investigation, he found the methodology behind blood flow restriction. There was a lot of backlash, and it took a long time for blood flow restriction to become popular in the United States until pretty much the late 2000s, around 2008, when some original research started coming out and people started accepting it. So some of the safety of blood flow restriction. Obviously, taking a cuff and applying it to your arm and restricting some of the blood flow while you're working out does seem pretty scary. But fortunately, when the proper equipment is used correctly, blood flow restriction training is very safe. There is no risks of blood clotting or nerve damage when it is being carried out correctly, and there's actually less injuries associated with blood flow restriction training than traditional exercise. So some of the physiology behind BFR. So we are imposing additional metabolic stress onto muscles by restricting the arterial flow and causing venous pooling in skeletal muscle. We are creating a hypoxic, low oxygen environment, which is going to promote the use of type 2 fibers, which we'll get into in a second. This is going to increase the lactate buildup, increase growth hormone release, increase mTOR C1 regulation, and decrease myostatin. So lactate, as we all remember from biology, and if we don't, it is one of the end products of anaerobic glycolysis. So we will end with pyruvate in a low oxygen environment. It'll be converted to lactate. Lactate is useful because it directly correlates, as you can see on the chart here, with growth hormone release. So by building up more lactate, there will be more growth hormone released. Growth hormone will help us build our muscles. By increasing mTOR C1, we are upregulating protein synthesis. And by decreasing myostatin, myostatin has catabolic muscle properties. So by having less protein breakdown during exercise, because we are going to be working out at lower resistances, we are going to allow for more protein synthesis to occur with less muscle breakdown. So here are three of the most common muscle fiber types we find: slow oxidative, fast oxidative, and fast glycolytic. Slow oxidative fibers are for longer term, lower intensity exercise. Fast oxidative is a bit of a mix of aerobic and anaerobic, and fast glycolytic is for fast, powerful movements. As you can see, the slow oxidative, you see a lot more red than the fast glycolytic. That is due to mitochondrial density, and that is because slow fibers tend to favor oxygen for metabolism, and fast glycolytic fibers tend to favor anaerobic metabolism. So muscular adaptations to exercise. So we have our hypertrophy pyramid here, which is metabolic stress, muscle damage, and mechanical tension. These are the three precursors to muscle growth. Traditionally in exercise, mechanical damage is the primary driving factor of muscular adaptations, but in blood flow restriction, metabolic fatigue is the primary driving factor. So by removing a lot of the mechanical damage that is occurring during exercise, we're able to produce more protein synthesis because there is less recovery associated with blood flow restriction, and you are able to get more adaptations out of it. So a simple way to look at it is the quantity of hypertrophy we're getting for exercise is myoprotein synthesis, the muscle protein synthesis, and muscle protein breakdown. In a catabolic environment, if we are breaking down more muscle protein than we are building, we are losing muscle. But if we are building more muscle than we are losing, we are going to get hypertrophy gains. So those are some of the resistance training adaptations. Here are some of the aerobic adaptations associated with blood flow restriction. So by limiting some of the venous return and causing venous pooling in the muscle tissue, there will be a subsequent decrease in stroke volume. So to compensate for this and to keep up with our cardiac output, we will need to increase our heart rate. So this will stimulate a cardiovascular response at a lower intensity, because lower stroke volume means we need to increase our heart rate to keep up with our cardiac output. This lovely chart here pretty much outlines how we get all of our adaptations aerobically with blood flow restriction. By decreasing arterial blood flow and venous return, you're increasing heart rate and creating a hypoxic environment with a lot of metabolite accumulation, increasing minute ventilation and angiogenesis, which is the formation of new blood vessels, and hematopoietic factors. And this will help raise your maximal oxygen consumption. Additionally, the reperfusion, once you cease using the occlusion during training, will increase arterial blood flow and venous return, which will impose shear stress onto arteries, which helps with your vasocompliance. So the importance of this is we can work out at lower intensities and still build muscular adaptations. This is a huge impact to athletes recovering from injuries that can't necessarily lift as much weight because of an injury to a joint, in elderly populations, because by limiting the oxygen to muscle tissues, we are going to favor the use of type 2 fibers over type 1 fibers, and from patients suffering from miscellaneous medical conditions, especially osteoporosis, and general population. So here we're comparing high-intensity training, blood flow restriction training, and low-intensity training. So some of the key things to look at here is the muscle damage that is occurring in high-intensity training is high. There are high releases amounts of creatine kinase, but in blood flow restriction, there's much lower levels. There is a similar lactate production to high-intensity training that in blood flow restriction, but that is not present in low-intensity training. And we are getting that type 2 activation as submaximal effort, which is a key here. And we are getting 1.7 times greater response in growth hormone and a significantly increasing IGF response and mTOR1C response. So sedentary behavior that is plaguing our country, as you can see from this wonderful chart here. Physical inactivity accounts for 1 in 10 premature deaths. Health complications related to sedentary behavior cost our country $117 billion annually. 60% of Americans do not meet physical activity guidelines, and 25% of Americans engage in no physical activity at all. Sedentary behavior increases all-cause mortality risk and increases risk for cardiovascular disease, cancer, diabetes, high blood pressure, depression, and anxiety. And some of this is very preventable by engaging in physical activity. Resting metabolic rate is the total amount of calories your body will burn when it's completely at rest. So RMR and your physical activity account for 90% of your total energy expenditure, hence the importance of including physical activity in your day-to-day life. So by increasing lean body mass with exercise, that is associated with having a higher resting metabolic rate because your lean body tissue is very metabolically active. Body composition is the analysis of your body mass. Usually differentiates fat mass from fat-free mass, and increasing fat-free mass and decreasing fat mass is associated with health benefits because we're raising our resting metabolic rate, we are burning more calories throughout the day. And as you can see, we get into the division of body fat from skeletal muscle mass from your organs, water, and bone. And it is important to have body fat, but by having too much body fat, it comes with health risks. Aerobic capacity is the quantity of oxygen that can be utilized by the body during exercise. So lower aerobic capacity is associated with health risks, and greater aerobic capacity is associated with health benefits. So as you can see here, it is showing the lactate levels to power output, and in trained individuals, you could resist fatigue longer by the ability to keep oxygen getting delivered to your muscle tissue. So now we're going to get into the research proposal. A needs analysis. Existing literature around blood flow restriction commonly analyzes only resistance training or aerobic training, and commonly does not look at both at the same time, and often doesn't focus solely on the sedentary population. So I wanted to look into the effects of blood flow restriction training on sedentary individuals, specifically on its effects on body composition, resting metabolic rate, and aerobic capacity. So this study will analyze the effects of BFRT on changes in body composition, resting metabolic rate, aerobic capacity in sedentary individuals compared to traditional training. So we'll have 3 groups: a BFR group, a traditional exercise group, and a control group that will not be exercising. So body composition, RMR, and aerobic capacity will be measured before and after the intervention. Body composition will be measured with air displacement plethysmography, which is the BOD-POD, and aerobic capacity and RMR will be measured using the VO2 max on a metabolic cart. So we are looking if fitness adaptations with BFR differ from traditional exercise in sedentary populations. My hypotheses is that the BFR group will have a greater decrease in fat mass and an increase in fat-free mass than the traditional exercise and control group, that the BFR group will have greater aerobic capacity than the traditional and control group, and that the BFR group will have a greater increase in resting metabolic rate than the traditional and control group. And the statistical analysis on this will be a 3x2 multifactorial ANOVA. The impact of this research is providing a new exercise modality to incorporate in an individual's life that is space-saving because there's less equipment needed because we are working at lower volumes. It is time-saving because BFR workouts fit into usually a 25 to 30-minute window as opposed to traditional resistance exercise, which can take usually around an hour. And it is less strenuous on the body because we are imposing less mechanical stress onto muscles, and there will be less delayed onset muscle soreness, which everybody does not want when they're working out. This also makes it so that you can work out more sessions. You can fit more sessions in throughout the week because you're going to be less sore from these exercises, and it'll take less of a toll on your body. And the benefit to the exercise science community is that this is a great exercise modality to add to a practitioner's skill set. It's a great tool to have in your tool belt, and you can incorporate it into workouts. And this research will show the effectiveness in sedentary individuals, increasing RMR, aerobic capacity, and body composition. The inclusion criteria for the study is 18 to 40 years old. We're going to define sedentary individuals as individuals that do not participate in at least 30 minutes of activity 3 days per week for at least 3 months, and active individuals that do participate in 30 minutes of activity 3 days a week for 3 months. The instructions for the study, we're going to advise participants to not alter their diets, food journal 3 days before the measurements, at the beginning and the end, advise participants to avoid exercise outside of the study, specifically instruct the control group not to begin any new exercise plans, and physical activity surveys will be collected prior to the start of the study to assign them to groups, and a familiarization session will be held prior to starting the study. So for the BFR group's intervention, it's going to take place over 4 days. We're going to have a back squat and a bench press at 20% of their 1 rep max at 15%. And for the aerobic training, there will be on the treadmill at 40% of their heart rate reserve for 15 minutes. The progression for the resistance training will be 2% volume increase biweekly, and the progression for the aerobic training will be 1 minute increase in time weekly. For the traditional exercise group, they'll be working at 60% of their 1 rep max for 8 reps for 3 sets for the bench press and the back squat. And on the treadmill, the protocol is the same at 40% heart rate reserve for 15 minutes. And the progression will be the same. The BFR bands we're going to be using will be B-Strong BFR bands. As you can see, the pressure varies based on which BFR band you're using, and that varies based on your dimensions and your limb size. Pressure could range from 150 millimeters of mercury to 350 millimeters of mercury, depending on how they feel and how much fatigue you're feeling. Recruitment for the study will be done in the greater Springfield area via flyers. Interested participants will be able to set up times to meet to go over informed consent and medical screening. Participants will be randomly split into a BFR group, a traditional exercise group, and a control group. Does anybody have any questions? There you go. Here we go. Dr. Lewis.
All right, got a good question here. You mentioned that you're going to measure or take food diaries at the beginning and the end of the program. Why is it that you're doing that?
Because when we are measuring our body composition, we want to see if they're altering their diets and if that could have been a factor that changed their body composition. And we want to try to advise them to not change their diets so we can limit that as a factor.
So you're ensuring that they're listening to you by not doing anything different.
That is the goal, yes. Dr. Lachowski.
Just a quick question on your protocol for these. Like, you think 15 reps per set is enough to build up metabolically for the type 2 fibers and activities? Do you think we should up that goal?
I think it is, based off the research I read and the existing parameters around it. There is all sorts of protocol, like BFR is very new in nature. Some research has anywhere from 20 to 30%, everywhere from 10 reps to 30 reps I've seen. I picked pretty much right in the middle at 15 reps. Also, I took into consideration the traditional exercise group at 8 reps, and I tried to correlate to make it as even as possible based off the available research and the existing literature.
So how would you adjust if they weren't fatigued?
If they weren't feeling fatigue, I would increase the pressure in the cuffs, or you could raise the reps.
Or what else would you?
You could increase the volume.
What did you do? Rest between sets?
Rest in between sets will be 2 minutes.
In between sets?
In between sets, each set will be, it'll be 30 seconds between sets for the BFR group and 2 minutes for the traditional group.
Can you tell people why you think we want a short rest period?
Because we are trying to accumulate metabolites and induce that venous pooling. Dr. Swart.
I have one that's more so an opinion, but I'm interested to hear your opinion on this one.
All right, let's go.
Would you agree with me that probably BFR is most prevalent in the clinical setting? Physical therapy, sports medicine, probably where it's used the most right now, currently.
So what you're asking is that it is most prevalent in the clinical setting?
Yeah.
Yes, right now it is most prevalent in the clinical setting, but that should be something we see changing in the future. You see some very prominent professional athletes, one of them being LeBron James, that commonly uses BFR training, and that could be a factor for his long career.
So all I want to do is just make sure we agree on that. Number two, the piece of it that's the opinion, outside of that setting, where do you see BFR being most applicable?
Yes.
Is it your population that you're looking to study, the sedentary population, or is there a different population that you see would have a bigger impact? That's interested in the sedentary
Yeah.
side.
Coming from a sports background myself, I would like to see BFR being used for recovery, specifically after a game. People are already beat up and sore. We could have them working out at lower volumes, inducing less additional fatigue onto them, and get blood flowing and induce that growth hormone response, which will help them recover.
I like that. So you're saying recovery as opposed to a method of attacking more hypertrophy or strength or anything like that.
It's totally another adaptation of it.
Recovery side. I like that. Good job, Chris.
Dr. Lachowski.
So one more thing, let's go on with Dr. Swart's idea of traditional strength athletes, right? So typically, if you're training some linebackers,
Okay.
who are healthy,
Okay.
right, we still want them to pick up or put down some heavy weights, correct?
Absolutely. We want the neural adaptations associated with lifting heavy weights. Yeah.
Right? How could you implement BFR with traditional training treatment, other than recovery? What else do you think you could fit in with their workout?
If I were to incorporate in a workout, in a traditional workout, I would have them usually at the end in like a circuit training format. So I get the aerobic capacity increases associated with that.
Why not at the beginning?
I wouldn't want to induce that much fatigue on them at the beginning of a workout. Dr. Pfefferly?
The basis for blood flow restriction is that we can get similar adaptations at a lower intensity, specifically hypertrophy,
Yes.
okay? Are there different types of hypertrophy?
Yes, there are.
What are the different types of hypertrophy?
myofibular hypertrophy and the so you're either increasing the amount of fibers or the amount of cytosol in the muscle cell, the sarcoplasm.
Myofibular, myofibula.
Myofibular.
What's the other one?
The sarcoplasmic hypertrophy.
Sarcoplasmic.
Yeah.
Ultimately, the goal of this is to improve performance. Which of those two types of hypertrophy would I hope or would I want to have more of after 87?
Which one would you want to have more of?
Yeah.
Fibers. Fibers are
Why?
because that's the physical property that's creating tension in the muscle, which is going to create more force.
You mentioned that one of the things that occurs with blood flow restriction training is there's an accumulation of lactate.
Correct.
And then you said that the accumulation of lactate has some sort of relationship with growth hormone, and growth hormone does something with hypertrophy.
Yes.
How do I get from lactate to growth hormone to hypertrophy? What is the connection between those two?
The connection is, well, with more free circulating growth hormone, there will be more opportunities for growth hormone to enter cells and incite muscular adaptations.
Okay? How does lactate affect that?
How does lactate affect that? Because lactate is, there is a correlation with lactate and growth hormone. I did not specifically look into how growth hormone enters the cells. That was a little bit outside of the scope of what I was looking into specifically.
Fair enough.
I do.
I have one quick question. How does GFR affect mTOR pathway? You talked about it, mTOR C1 pathway.
Because there's an upregulation of protein synthesis. Okay. You're welcome.
Okay, next I'd like to introduce Jack Yvonne. He has done a review of literature on the impact of exercise on COVID-19 symptoms.
All right. So I'm Jack. As Dr. Lewis says, I did a review of lit on the impact of exercise on the symptoms of COVID-19. Brief overview. I started with my research question of how does exercise impact individuals who are experiencing symptoms of COVID-19. More specifically, I looked into hospitalization rates, ICU admission, and deceased individuals as a result of having COVID. Looked into cardiorespiratory fitness and moderate to vigorous physical activity. And I also looked at the immune response and vaccine response that exercise might have. A reason of interest for this is just the relevance of COVID in today's day and age. And exercise is used as a tool to help combat chronic diseases such as, diabetes, cardiovascular issues, obesity. So another reason why I just kind of want to see what role it played in infectious diseases. So I looked at the three main articles that I'm going to explain are the three main articles that drove my topic. So the first one was physical inactivity. Physical inactivity is associated with a higher risk for severe COVID-19 outcomes. Dr. Robert Salas ran this study, and his main objective was that he aimed to compare hospitalization rates, ICU admissions, and mortality for patients with COVID-19 who were consistently inactive, doing some activity, or consistently meeting physical activity guidelines. He used the United States Physical Activity Guidelines, which is 150 minutes per week of moderate to vigorous exercise. And then he further broke that down into three separate groups. The first one being consistently inactive, which is a self-reported value of 0 to 10 minutes of physical activity per week. Some activity, which was 11 to 149 minutes per week, and consistently meeting guidelines, which is 150 plus minutes per week. So the participants, he identified 48,440 adults with a COVID-19 diagnosis from January 1st of 2020 to October 21st of 2020. The patients had to have at least 3 exercise vital sign measurements from March of 2018 to March of 2022, so 2 years prior to the pandemic. And exercise vital sign, also known as EVS, is used for every outpatient encounter within the KPSC system since 2009, and that's a medical facility in Southern California. And what they do is they ask a series of 2 questions about physical activity, just basically how frequently you engage in physical activity, and kind of they ask about the intensity of what you do it. And to the right, I kind of have a chart that shows the original numbers that they had, and then how it kind of dwindled down based on the criteria to their final number of participants. So they conducted multivariable logistic regression controlling for demographics and known risk factors to assess whether inactivity was actually associated with COVID-19 outcomes. And what they found was that individuals who are consistently inactive were 2.26 times more likely for hospitalization due to COVID. Individuals who are consistently inactive were 1.73 times more likely to be admitted to the ICU. And individuals who are consistently inactive were 2.49 times more likely to pass away than those who weren't. And in figures 2, 3, and 4, the first one is the exercise frequency in the hospitalization rates in patients with COVID-19. Figure 3 is the one for the ones who are admitted to the ICU, and figure 4 demonstrates the ones for deaths. So, in conclusion, patients with COVID-19 who were consistently inactive during the 2 years preceding the pandemic were more likely to be hospitalized, admitted to the intensive care unit, and die than patients who were consistently meeting physical activity guidelines. And meeting the guidelines was also associated with substantial benefit, but even with those of doing some activity, it would show that they were at lower risk for severe COVID-19 symptoms as opposed to those who were consistently inactive. Some strengths of this study, the demographic diversity, it actually used a 65% Hispanic population, which is something that you don't really see. There was women involved, and the ability to adjust for a range of demographic and health variables. And it was also a large sample size, which is always good. Some limitations, the self-reported levels of physical activity. As we know, it's not always the most accurate way to go about things. And there was also no measure of intensity of exercise, so someone's moderate to vigorous self-reported level intensity could be different from the next. And moving on to the second study that I looked at, it was titled Fitness, Strength, and Severity of COVID-19. And the objective of this study was to investigate possible connection between cardiorespiratory fitness, also known as CRF, and muscle strength in early adulthood and severity of COVID-19 later in life. So this one was pretty interesting because it used Swedish men who were in the military from 1968 to 2005 with a mean age of 18.3. And the reason why they did this is because when they enlist in the military, Sweden has them do cardiorespiratory fitness assessment as well as strength assessments. And the main outcome that was measured was hospitalization, ICU admission, and death due to COVID-19 in relation to cardiorespiratory fitness and muscular strength. They developed a CRF score. Subjects performed a psychoergometric test where the work rate was increased progressively until exhaustion. Based on the final work rate, a 9-level score based off of the National Service Administration in Sweden was a standard measure of CRF. And then this study further categorized them into low, medium, and high categories. The muscle strength score, what they did was an isometric muscle strength in units of Newton. And the weighted sum of knee extension, elbow flexion, and hand grip were used for that score. They controlled for morbidity, BMI, blood pressure, and height at baseline. So then what they did was they linked the men's personal identification numbers to the Sweden's National Hospital database, and they looked at hospitalizations between the individuals who were affected by COVID, ICU admissions, and deaths. And what they found was that the results showed statistically significant results that there is a protective association between a higher CRF score in adolescence or early adulthood and hospitalization, ICU admission, and death, and that there is statistically significant results that a higher muscular strength score is associated with less hospitalizations, ICU admissions, and deaths. And here, the chart on the left shows their categories of fitness, and on the bottom it shows the odds ratio, so the more likely you'll be hospitalized, admitted to ICU or mortality. The higher the value, the more likely you are. And the blue is medium, and in the red is high. And as you can see, the high CRF, so people with high cardiorespiratory fitness are less likely to be hospitalized, admitted to ICU, or die. And same goes with the muscular strength values. So in the conclusion, the findings in the study reinforce the importance for promoting regular physical activity in early life to increase cardiorespiratory fitness and muscular strength. It also might have indicated that fitness at a young age may influence the severity of COVID-19 later in life. It did say how more research needs to be done, and that there hasn't been any other studies quite like this one that looked at measurements from when they were younger and compared them to COVID-19 and how that impacted them. Some limitations, they didn't distinguish what low, medium, or high CFR scores were, which I found to be kind of odd. And that goes back to the 1 through 9 scale that they had. And the results can only be generalized to men because in the Swedish military, they didn't force women to enlist when they were 18. And the changing protocols for CRF and strength over the years have limited the amount of people that they could use. That's why it's from 1968 to 2005, because before that they were different, and after 2005 they were different. Some strengths, it's a large sample size, and it used objective measures of strength and cardiorespiratory fitness. And lastly, the last article that I looked at the effects of regular physical activity on the immune system, vaccination, and risk of community-acquired infectious disease in the general population. The objective in this study was to observe the association between chronic physical activity and the risk of community-acquired infectious disease, laboratory assessed immune parameters, and immune response to vaccine. And they had 3 separate questions what they wanted to answer going into the study. The first one being, does engaging in habitual or chronic physical activity decrease the risk of community-acquired infectious disease and related mortality? The second being, does engagement in physical activity improve immunosurveillance and response? And lastly, does engagement in physical activity increase the effect of immunization? So they conducted a systemic review and meta-analysis. They searched 7 databases for observational studies and randomized control trials. They included studies that used adults and excluded studies that used highly trained men and women athletes. They wanted to more look at the general population. And they included studies that examined chronic physical activity or regular exercise programs. And they ended up using a total of 55 studies. So for immune response, they found higher concentrations of CD4 T cell helpers and salivary immunoglobulin IgA, and a lower concentration of neutrophils. Physical activity interventions lasted an average of 12 weeks and included aerobic, so things like walking, running, cycling, swimming, or resistance training, or a combination of both aerobic and resistance training. The protocols went for about 3 to 5 days a week on average for 30 minutes at moderate to vigorous intensity. And what they found is that it's unclear as to how time, frequency, duration, and type of physical activity influence the effect of immune defense. For vaccine response, they found that pooled effect showed a statistically significant effect of physical activity compared to the control, with higher antibody titers. And the median characteristic of training programs were three sessions per week of 60 minutes for 20 weeks prior to vaccination involving aerobic or combined aerobic and strengthening exercises. And what they didn't directly look at COVID-19 vaccination. They used H1N1, H3N2, and pneumococcal. So in conclusion, the meta-analysis shows that a higher level of chronic physical activity are associated with a 31% lower prospective risk of infectious disease and a 37% lower risk of infectious disease-related mortality. Engaging regularly in moderate to vigorous physical activity is associated with the increased strength of the mucosal immune barrier, which is that salivary IgA immunoglobulin, and higher concentrations of immune cells that prepare, orchestrate, and regulate the effect of immunity, which are those CD4 T cells. And engaging regularly in moderate to vigorous physical activity could strengthen vaccine response. That's it's kind of a controversial look at things. It's not really known whether or not exercise actually does affect that. And more research is definitely needed to verify that. Some strengths of this study: it was a wide-ranging, systematic search strategy. Had a comprehensive quality assessment of primary sources. It didn't allow any self-reported values. And some weaknesses is the evidence is not large enough to be able to understand more precisely the impact of time, intensity, duration, frequency of physical activity, and how those variables differ from population to population. Some common themes that I saw were that all these studies showed that regular exercise is linked with a lesser chance of hospitalization, ICU admission, and death from COVID-19. Regular exercise can benefit all populations in many ways, including a kind of protection against COVID-19. And all studies conclude with stating that exercise should be recommended to control the ongoing pandemic for all populations. Some gaps in the research. As we all know, COVID-19 is still a very new disease. It's still in its infancy stage. There hasn't been enough time in order to conduct the proper amount of research, and especially with how exercise impacts that. I know that I definitely had a tough time finding actual legitimate research that had exercise and how it affected COVID-19 symptoms. And as I stated before, more research is needed to determine proper time, duration, frequency, and intensity of physical activity. And I just want to thank you guys for your time, and I welcome you to any questions or comments you might have. Dr. Lewis.
So, I don't know how far you went with this, but did it give you any ideas on the type of research you might be interested in doing as a result of this video?
Yeah, like me personally, what I would look for in the future, I would look more towards the older population, because I think that they're more of a forgotten population when it comes to exercise. I think, in general, people are scared to train them and don't think that they can make adaptations. And I think that, well, I know that the older population is one of the higher risk categories for COVID is the age. So I think that would be a really interesting niche to go into. Dr. Lachowski.
Obviously, there is some great research coming out on
Mhm.
how, of course, physical activity and exercise impact your immune response, correct?
Yeah.
Potentially could decrease your chance of possibility of disease and so forth. Why do you think, I don't see that anywhere being promoted out there?
I know. I actually saw, while doing research, just like an ad in South America, which actually started to promote physical activity as a way to help combat COVID-19. So I definitely think that, you know, it should be promoted like that. It's a huge issue.
Then how do you think, as a science professional, how do we bridge that gap? Like, what are we supposed to do? We're all sitting here kicking and screaming, trying to say that physical activity, increasing physical activity, exercise is going to help you. How do you think we can work together with other sports medicine or allied health professionals to promote?
I think that it just comes down to educating. You know, the more people know about the benefits of exercise and how exercise, you know, literally is medicine, you know, it's the best thing you can do for yourself in the most natural way. So I think just educating people the best you can, and hopefully one day we can get there.
Absolutely. What do you think about you as a professional maybe talking with physicians? Because
Mhm.
who interacts with patients the most? Not us.
Right. It's
It's the nurse
doctor, yeah.
practitioners, it's the physicians and so forth. So do you think there's a gap there where we can kind of work together on actually
Yeah.
promoting health care, right?
Definitely, yeah. Dr. Swart.
Yeah, Jack, I was trying to word my question similar to what Dr. Lachowski was doing. She did a better job of it, though. So I'm going to go down a different road a little bit.
Okay.
I think one of the biggest challenges for, like, the younger generation within this field is that messaging. How do we, because everybody knows intuitively that exercise promotes good health, but how do we package it in a way that's palatable for the average person, right?
Mm-hmm.
I think that's a big part of the challenge that you guys are definitely going to face.
Right.
So how do you do that? Like what is the best avenue from the standpoint of outside of education? Do we start going towards social media? Do we start going towards TV? Like where do we spread our time and effort at a young age in schools? I just don't know where we go with it.
I mean,
Hold on, time out, not to cut you off.
mhm.
The big point I wanted to make was this. Unfortunately, this is what happens, and this was the real root of the question. My parents are similar in this nature. It took me a long time to get them out of this mindset. They said to me one time, well, geez, I take a pill, and
Yeah.
that pill can down, my A1C goes in a normal range, for example, right?
Mhm.
So people in the general public do have that mentality that I think we also have to challenge with as well. The standpoint of, oh, well, the doctor said now it's normal, and so am I. How do we basically get them to understand all the outside aspects of health and fitness in their opinion?
I think it just comes down to being more preventative based than as opposed to treatment based. I think today's society is very heavily into, like you said, just take this pill and you'll be fine, which is a treatment. And I think that, from a young age, we should all be educated and learn about physical activity and just getting outside and being active. I mean, it's the best way to do it.
Is there a research on the comparison of the exercise and the immune response versus the vaccine immune response? And are they equal, or is one more than the other?
I didn't look too far into that. There are different studies that just deal with exercise and the immune response, and different studies that involve exercise and vaccine response. There's definitely more about immune response because the research that I read on vaccine response it differed a little bit. So that's definitely a newer topic and a newer avenue that they're going down. So there's definitely differences if that's what you're asking.
Here's the thing. Do you think that the immune response for following into that effect is increased compared to the immune response? In that way, could protect you more from an infected disease than the vaccine itself?
So in someone who does exercise and someone who doesn't?
Yeah, in a person that does exercise.
Yeah, I definitely do.
And also, if a person starts exercising, could that benefit them equally as if it was to get a vaccination?
Chronically, it would. Acutely,
No.
I believe, from what I read, I believe acutely you have decreased immune function. But as a whole, yes, you end up at a better position than you would be if you didn't exercise. Dr. Pfefferle.
The basic premise of your presentation is that individuals who are able to participate in more physical activity on a regular basis are more resistant to infectious disease, specifically COVID.
Correct.
Could there be extenuating circumstances or variables that leads to certain individuals being able to participate in physical activity more so than other individuals, and that the individuals who participate in physical activity are going to?
So are you talking about the access people get to, or?
Part of it, yeah.
Yeah, I'd say there's definitely a social factor that goes into it, demographic factor,
Specifically, what social demographic factors are you talking
I would say race is a big one. How much money someone has, because with money you are more able to afford, going to a gym or, engaging in a sport, so to say. And yeah.
beyond messaging and educating people, which is obviously important to do? If I'm trying to message and educate someone who is working 70 to 80 hours a week, has to go home, take care of their kids, is working in a high-stress job,
Mhm.
is that necessarily going to have any effect on their ability to perform physical activity on a regular basis?
Yes.
Okay. What type of effect would it have on their ability to perform physical activity on a regular basis?
They just wouldn't be able to fit it in. They wouldn't have time.
So,
They're probably already stressed out as it is,
yeah,
you know.
do you know, if we come through this pandemic, what groups of individuals have been most affected by COVID-19?
Affected in what way?
Within the United States, there are certain demographic groups that have been more affected by COVID-19 than others in the country.
Are you talking about like race or
Race and what else?
like socioeconomic status?
Yes. Do you think that there's some overlap between those groups, racially and socioeconomically, that have been most affected by COVID-19, and those groups that weren't able to participate in physical activity to the same extent?
Yeah,
Yeah, I would say so.
Definitely.
So, can we message our way out of this, or is there something we can do to fundamentally change about our society that will enable those folks to have access?
so you're asking like what can we do so that everyone can get?
I'm asking you, I can educate, this is what Dr. Fork was talking about. Why have I'm a patient who's going to a clinic.
Mhm.
I have diabetes, hypertension, dyslipidemia, XYZ other chronic conditions. The doctor tells me, you need to change that, you need to make some lifestyle, you need to start exercising.
Mhm.
And I look at that doctor and I say, when am I supposed to do that? When I'm having to work 2 jobs to support my family. Is that messaging and education going to have an effect?
No.
Probably not. So what do we need to do, or work to do, so that those individuals, the broadest portion of society, has access to the same type of physical activity that you and I might do?
Make it more accessible. You could. Isn't there like I know there's a wage difference between, people of color and white people, and women and men. Is that what you're like looking
Yeah.
for here?
Yeah.
Okay. Thank you. Any more questions?
Doing exercise during like having COVID, does it affect your physical activity? Like being positive of COVID-19?
So exercising while
Being positive.
being positive for COVID-19, I didn't look into any. I don't think that there is any literature with that. I don't think. Yeah, I didn't see any at least, so I can't. I'm not really too sure about that. Good. All right. Thank you guys again.
history of it, who discovered it.
I give the PDP forms to you, or
Like all of them?
I have 7 out of 3. I need to sign 3 from my coach.
Okay, yeah, when you're ready, I can sign all of them for you if you want. And then, once they're all signed, then you bring them to Tracy
Okay,
Thomas,
yeah.
who I think is left. But she'll like make, I think, scan them and all that good stuff. You have them here now? Then
You need to sign.
I can sign them when we're done, or tomorrow, whichever you like.
When you're done with them, I've never seen that before. Fill that form out.
Yeah, I already have the forms.
No, like the entire reporting form that they use, fill it out. Just have a size. No comment. And give it all together.
Wow.
Easier for them. It's on their own screen. It's like an Excel spreadsheet. Yeah, like that, but one where like has all your, it's like a big reporting form that's faculty uses. Fill that out.
So I guess it's on the same.
It's on the website, it's on the same page. So you fill it out, take it on here, and you're all set. Come on, man. That is true.
That is very true. I like it.
But I'm not a golfer.
That's green for the kids.
I know.
There you go. So you matched it.
Cannabis. Hey, that's right.
You matched it. I forget, it was one of my jobs that I worked with one time. One of my colleagues, she would always match her shirt or whatever, something on her to the presentation color. Every day. Every day. Every day. So like when she made her presentations, they all had like a different theme color. And she would wear like that color shirt. Every time, whatever it was. It was awesome.
I can start getting blue. I can't have one. I can't have green. Go get it.
Some vague idea about like pituitary afferent signaling for growth hormone release. Oh my god. What physiology? You're on it, yeah. Yeah, you did good. I just know. See, Jack, I feel like the lack of perception here is like specifically when you're like, I don't know, it's like a good answer. Yeah. Like I know in your head it's fish, but like it looks like you know, like it sounds like very good, you know? Like it looks like you know what you're talking about. Something's off the path. Like, seriously.
I think just Pedro. Okay. All right. So now I'd like to invite Lindsay Amaral to come present her research. She has done a research proposal. And the title of her proposal is Impact of Burnout Syndrome on Cortisol Levels in Collegiate Athletes.
Thank you. Okay, hello. Like Dr. Lewis said, I'm Lindsay Amaral. My research today is on burnout syndrome and cortisol levels in college athletes. I chose this topic just because for the fact that AIC's central focus is mostly athletes. So I feel like a lot of people in the room can either relate to some of the symptoms or have an idea of what burnout is. So it's just an overview of what I will be talking about. I'll be talking what burnout is, the causes, the symptoms, some sport type differences, sex differences, differences between scholarship and non-scholarship, the academic performance, and then I'll go into my research proposal. So there's no consensus on the definition of athlete burnout. There are many different researchers that propose different definitions, but the one that I saw a lot was the Radek 1997 definition, and the definition is the symptoms of 3 different elements, which are physical or emotional exhaustion, sport devaluation, and reduced athletic accomplishment. Another definition I liked was from Allen. This is the psychological, emotional, and physical withdrawal from a sporting activity, formerly perceived as enjoyable as a consequence of stress. So there's no one reason why burnout occurs, especially in athletes. There could be multiple symptoms, there could be different reasons, but I just listed a few, and this is, one of them is competitive stress, the level of confidence in that athletic ability. So if the athlete is confident in what they are doing, perceptions of social support surrounding them, the severe practice conditions, so how training and practice are organized and how intense they are, extreme physical fatigue, pressure from coaches and parental pressure. I saw in one study that obviously coaches may have an increased risk of maybe coming into like the play of the role of the symptoms of an athlete just because of the pressure they put on that athlete, wanting them to perform to their level. And then the parental pressure I found interesting because I never really thought about it. It's the research I saw on it was kind of the parents want to kind of live through their child in a way, which can cause the athlete to feel as if they need to live up to that certain expectation and eventually go to college, like with a scholarship of a sport. And then the constant pressure to win, train, and perform can go along with the pressure from coaches or how the intensity and organization of a sport is. And then the main reason for burnout in sport is investing so much time and energy and not experiencing the enjoyment or reward. So once you realize you are playing a sport basically for nothing, you don't enjoy it anymore, that may be the reason, one of the main causes of burnout. So there are a lot of different symptoms of burnout. I tried not to list all of them, but there's still a few. So there are some psychological, which can do with concentrating, forgetfulness, moodiness, irritability, low self-esteem, increased anxiety, depression. Motivation may decrease, and there might be some sleep disturbances, which can then lead to the physiological symptoms of burnout, which can be increased in excessive and chronic stress. There can be injuries, illnesses, overall exhaustion, reduced quality of family and academic life because you were focusing so much on the sport, which I'll be talking about in a little bit. The one study showed the drug and alcohol increase in burnout athletes, which I thought was interesting. And then a higher heart rate and blood pressure. And some athletes who are considered burnt out may have weight loss or gain and may experience losses of appetite. So I looked into sport type differences. I looked into one study that showed that team-based sports had a higher risk in general of levels of burnout. compared to smaller team-based sports or individual sports such as tennis, golf, and track and field. I then looked into another study and it concluded that overuse of injuries are higher in contact sports such as football and soccer. Obviously, football and soccer are contact sports, and there may be injuries in the sport, and athletes who are burnt out may have those injuries and keep working through them, and eventually they overuse not only the injury, but you overuse the body, which can lead to psychological and other physiological effects. One study that was older, but I thought it was interesting, were the sex differences. Women had higher levels of burnout compared to their male counterparts, and they demonstrated that perceived stress and emotional exhaustion were to do with the reason women had more levels of burnout. And I don't know if it may have to do with the menstrual cycle and the levels of estrogen. And then another thing in the study showed that role models and gender differences in women were higher than their male counterparts. They were basically saying that women should be more of a role model than the male counterparts, so that could be a stressor for those who are burnt out, which I thought was interesting. And then women need more social support, which can cause more levels of burnout. Usually males tend to hold in more things, and women seek help from others, which may have them rely on other people more, which can lead to stress. Then I looked into scholarship versus non-scholarship. I looked into this. It was a study on Division II athletes. This study showed that women with no athletic scholarships had higher levels of reduced athletic accomplishments. This may have to do with the fact that they were not getting anything from the sport, such as like a scholarship, so they kind of felt like they shouldn't really be there. And then women with athletic scholarships were top tier academically. This probably has to do with the fact that in order to keep an athletic scholarship, you have to perform academically as well. And this also showed that men with scholarships had lower levels of burnout than women with scholarships. And then in general, the study showed that men and women with scholarships reported high levels of burnout compared to their non-scholarship athletes. And then I went into academic performance, and this study I looked at showed that there are burnout in collegiate athletes. Not only can the burnout be athletically, but it can also be academically as well, because academic burnout can lead to academic stress can lead to academic burnout. The stress associated with the need to balance sports and academics can be the major symptoms of burnout. And then as a performer, as their performance decreases, they are at risk of losing scholarships. And then over the recent years, NCAA put in some eligibility rules. So for like Division I and II, they have to have a certain GPA according to the NCAA, and then Division III, it's based on their school. So my research question is, do college athletes who are burned out have higher levels of cortisol than college athletes who are not burned out? So I then go into defining what cortisol is. It's a major catabolic hormone that plays a role in our stress response. It can be due to any events or circumstances. It is secreted by the adrenal glands, and it is in the role of our fight and flight response and then it provides the body with energy. And then I looked into the general adaptation syndrome, and this is when the body goes through a certain stressor, and then they need, sorry. The body goes through a exposed type of stressor. So this visual shows that the first stage is the alarm phase, and where the line is that homeostatic balance. And then once someone is exposed to that stressor, such as like exercise, their cortisol is released, and then their fight or flight in the sympathetic nervous system is activated. And then the body wants to repair itself, but they are resisting. So they want to return back to a homeostatic level, which they end up, if they do not, they end up going into the exhaustion phase. So this basically shows how the body adapts to stress during burnout. So the body's ability to adapt to stressors is significantly hindered due to elevated cortisol levels in the body. They are not able to regain that homeostasis level due to that prolonged stress that they encounter. So I did the connection between burnout and cortisol levels. The body releases the cortisol when it experiences acute, chronic, or traumatic stress, which can all be reasons of burnout. Cortisol is significantly associated with altered physiological states in response to stressful situations. This is the primary measure for stress and arousal assessments in athletes. There are increased cortisol levels that are associated with increases in anxiety and depression and all the other symptoms that lead to burnout. And then, as I kind of showed in the previous slide, that prolonged stress are solid predictors of burnout. So I looked into my review of LIT, and then I went into a study on cortisol that showed the relationship of cortisol and exercise. In this study, it focused on 13 runners and 13 non-runners, and they did a 30-minute treadmill run at 60% of their VO2 max. They measured the cortisol levels before, during, and after their exercise. And these results didn't really help my research, so that's why I wanted to do a research proposal and expand. So basically the results showed there was no differences in the non-runners and runners in the cortisol levels. And then I went to another study that showed the cortisol levels in relationship to burnout, and these only focused on middle school and high school children, so not collegiate athletes. So they're in sports like football, baseball, track and field, and soccer. They focused on the last 2 weeks of the season, and they didn't do an exercise. They just measured the athlete burnout, self-comfort, blood volume, pulse, and respiratory rate. And the results did show that cortisol increases associated with significant increase in burnout. And they also showed that high levels of distress experience higher mental exhaustion due to feelings of discomfort with self or teammates and coaches. So the purpose of my study is to compare resting and exercise cortisol levels between burned out athletes and non-burned out athletes. So I decided my methods would be college athletes, and I would focus on aerobic sports such as soccer, lacrosse, and cross-country teams here at AIC. I would have the athletes be from 18 to 23 years old, both female and male. And then I decided I am only measuring the last 2 weeks before their regular season ends. And the equipment that's needed is the label kit and swab for the cortisol, and then the athlete burnout questionnaire. That is a validated study in order to determine whether or not the athlete is burned out. The groups will be split into athletes experiencing burnout and athletes not experiencing burnout. And then I'll be measuring their pre and post exercise cortisol levels. So, like I said, the measures would be the athlete burnout questionnaire to see if they are burned out or not. This is a 15-item scale that focuses on the emotional and physical exhaustion, sport devaluation, reduced sense of accomplishment in those athletes. And the scores are calculated in the means of points. And then I'm going to focus on the cortisol. I'm going to focus on taking them from 3 to 5 p.m. And I'm going to refrain from food and drinks 90 minutes prior. And then I'm going to measure their baseline and then measure 25 minutes after exercise. So for the procedure for visit 1, 3 weeks before the end of the regular season, I am going to stick with that 3 to 5, like I said. And this is a week prior to when I am measuring all of their cortisol and their treadmill tests. They're going to do an informed consent, and then they're going to fill out the athlete burnout questionnaire to determine what group they're in. They're going to measure their VO2 peak with their boost protocol. And then for visit 2, this is also from 3 to 5, and this will be a week later. And that's 2 weeks left of the regular season in the sport. And then I'll measure their baseline cortisol measurements with a 30-minute treadmill run at 60% of their VO2 max. That was from the boost protocol. Then post-exercise, cortisol levels will be taken 25 minutes after. And the statistical analysis I'll be using is the 2x2 multifactorial ANOVA. And then my hypotheses at the end of this study is that athletes who experience burnout will have higher resting cortisol levels than athletes who are not burned out. And then post-exercise cortisol levels will be higher in burned out athletes compared to non-burned out athletes. And these are my references.
Lindsay,
Yes.
let's say, for example, an athletics department created a new position for you.
Mm-hmm.
And I don't know, a burnout-ologist, okay? You just got elected, and you have an unlimited budget, so you can do whatever you want. That's never going to happen. But let's say it did. Cortisol is going to be obviously something that you would measure. And I know this is outside of your topic, but I think I'm interested as an exercise science student to hear your thoughts. What else would you measure if you had this job as the burnout-ologist? What else would you look for in these athletes, or how would you use cortisol in your practice to help coaches make better informed decisions?
I think I would, this kind of relates to stress, but I would look into their fatigue of like performing a exercise. I would also not only focus on the last 2 weeks, I guess. I could focus, maybe it could be their whole 4 years in college. Like, because I feel like that's a lot of time and money to put into. I don't know what else I would do.
Yeah, no, that's perfectly. I mean, in a lot of athletic departments, there's like this disconnect just in communication between, the athletic trainer, the strength coach. Now, Division I programs, you've got sport nutritionists, you've got sports psychologists, and all those tenets just have to work together to be able to, have one common narrative to the athlete. Here's where you stand. And we just don't really have that successfully in a lot of programs. Once again, that's another really key avenue that, we as younger professionals that still have decades to go can really play a key role. How do we do that? And it plays right in line with this presentation. We need more research in this area. So great job, Lindsay. Excellent.
Yes.
Good job. Quick question for you. So you are going to, in your method, you like to measure cortisol levels in males and females. Okay, are they mixed matching groups?
Yes.
So my next question for you is going to help you lead you to this answer. Let's talk about females first. Okay, so what do females have that they have to go through every month?
The menstrual cycle.
The menstrual cycle, there you go. Are there different cortisol levels you read at all during the different stages of the menstrual cycle? Do they sometimes spike depending on where a female is in their menstrual cycle?
I looked at a study that showed that I would focus on the luteal phase of a menstrual cycle just because that's when the cortisol levels are the lowest. during the folic, yeah, folic. Yes. Yes.
Two questions.
Okay.
I'm forgetting what the second one is. Bear with me while I get there. But the first one, straightforward. You said in both visits, you look at them between the hours of 3 and 5 p.m. Why did you choose that time period?
I chose that time period because when I looked into research, I saw that cortisol levels do fluctuate throughout the day, and they're the highest in the morning. And during that time period is where they tend to be the lowest. They tend to be the lowest at night. But that's what most of the research I looked into, that's what they recommended as well.
Excellent. The second question is more of a thoughtful kind of your ideas or opinions kind of question. So, since athlete burnout, student athlete burnout is really strong, do you have any ideas on what could be done to support student athletes to help possibly reduce the chances of burnout and to support them academically?
Academically, I mean, I feel like we should, like as a trainer or a coach, I feel like this should be talked about, like as Dr. Swart was saying, like we need to be well known about this, especially as athletes. Academically, I feel like there is academic burnout as well, so I feel like athletes should realize that it shouldn't be like one or the other, and they should be like equal in a way, I guess. I don't know, yeah. Yes, Lewis.
Why, you talk about athletes, but you said earlier in the study that team sports have higher rate of burnout. Why would that be?
I think that team sports probably have a higher rate of burnout due to how competitive the team sports are compared to the individual sports. So like golf and like cross country and stuff, they're more focusing on their own game, while team-based sports are focusing not only on their game, but they're stressing about other players' games, trying to be the best and competing for those positions.
And then, how could you create a more positive environment in team sports?
A more positive one? I guess we can incorporate, I know here at school we do like little council groups with a psychologist, and we talk about a team building and stuff. I can feel like they can focus on burnout and more do like team-based stuff, and just maybe that can help with the better environment.
Another question for you. You didn't mention any control groups. What would be your control group?
If I were to do a control group, I think I could do the non-athletes who are academically burnout, maybe.
What'd you say? Oh, okay.
All right, last but absolutely not least, we have Lucas Booth, and here's the title on here, the thing was taken away.
Okay.
Cannabidiol CBD treatment for concussion symptoms in mixed martial arts athletes.
Thank you. I wish I had a clicker, but we'll make do. with what we have today, but as Dr. Lewis has said, my capstone was on, it is, more specifically, it's a review of literature on whether cannabidiol or CBD can mitigate the concussion symptoms experienced by mixed martial arts athletes. I chose this topic because I did previous research on traumatic brain injuries in contact sports, and I'm interested in the cannabis substances and mixed martial arts in general. And also, mixed martial arts athletes have been well known to use cannabis substances to help with inflammation and recovery. And the two main cannabis derivatives that we'll be talking about is THC and CBD. THC, as everybody knows, is associated with high sensation or euphoria, while CBD is primarily known for its therapeutic effects without the high sensation. And with combat sports, we all know, or should know, that a concussion is inevitable, as the goal is to incapacitate the opponent. Athletes participating in boxing and mixed martial arts need a safe and effective treatment for concussions to improve their quality of life while active and retired. So, two guys that are very important for this presentation are Harrison S. Martland of 1928. He was pictured on the right here. He was a pathologist who pioneered the phrase punch drunk syndrome, as he documented his findings from autopsies of boxers. And punch drunk syndrome is specifically a condition of cognitive impairment caused by repetitive head impacts, similar to that of the modern condition called chronic traumatic encephalopathy, or CTE, as discovered by Dr. Bennett, pictured on the right, as he found that in, or left, as he found that in retired or deceased American football players. And a mild traumatic brain injury or concussion is a complex physiological condition consisting of a biomechanical component and a physiological component. And a concussion is considered a mild traumatic brain injury because there's no immediate structural damage to the brain. This diagram by Lang et al. 2015 depicts the relationship between Alzheimer's disease and CTE by detailing the disruption of neurons following a mild traumatic brain injury. And this illustration describes the impact of concussions on the brain in greater detail than the one by Singh in nearly 2020, shown on a different slide. So we'll get to it later on. But now we're going into the signs and symptoms of a concussion, which you have to be aware of or cognizant of. We'll just keep that pun out there. So some of these symptoms are as far as you have a headache, you have nausea or vomiting, balance problems, dizziness, blurry or double vision, and last hypersensitivity to light and sound, as many of you have probably experienced as athletes, and last but not least, mental fog. It's hard to think when you're concussed. It's hard to think it's hard for me to think anyways, but some signs are your recall impairment. I have that anyways. Of the before and after events of following a hit or strike. You have your appearance of stunned, in being dazed or confused, or forgetting instructions, your assignments or positions, clumsiness, slow responses, brief or complete loss of consciousness, and last but not least, changes in mood and behavior, personality in severe cases, or repeated exposure. The concussion consists of two injury phases, primary and secondary. The primary injury phase is considered the moment of impact, or the strike, the head being impacted with the strike of an external force to the head. It causes the rapid acceleration and deceleration of the brain against the skull, causing shear forces or stretching forces. It stretches neurons. Boxers and mixed martial artists only contend with body segments, such as your hand, your foot, your knee, your elbow. Yeah, that's pretty much all you can think of. Which possess less force than the entire body, as in football. And you have your pads, so they think it's safer, but it isn't. And Maroon et al., 2015, examined brain tissue from deceased football players and found 153 cases of what's considered CTE, of which boxers and football players consist of most of them. Not shocker. And then, Delson et al. Suggests that the science of concussions can be explained by 3 basic concepts. We need a defibrillator for you guys? Whatever. It doesn't matter. We'll be fine. Whatever. That was probably a joke, but you guys didn't laugh. It doesn't really matter. Physics is a rough subject here, as everybody knows. If you guys taken physics as PT students, I know Julian has taken physics. It's deadly. Well, the force equals mass times acceleration, or the Newton's second law. Your torque and kinetic energy equations can also explain this. So an athlete with more mass will produce more torque and kinetic energy. This is simply known as power. So your increased power leads to increased magnitude of your shear forces transmitted to the head, which increases the severity of your condition and possibly loss of consciousness. Next, we have the secondary injury phase, which is depicted by this guy, Singh and Neary, 2020, which is this diagram, and the previous diagram, which is Ling et al., 2015. Both illustrate the secondary injury phase of the concussion. The difference is that Ling and Neary describe the connection between TBI, CTE, and CTE development. In my opinion, this diagram for the secondary injury phase is way more comprehensive than the other one, because that was just confusing to me. Oh, sweetness. How do we use this? First of all, there we go. So the next slide just shows you about the metabolic impact of it. So this is also singing nearly. They described the impact of the glucose metabolism and oxidative metabolism. And these authors indicated that glucose metabolism increases acutely 30 to 46% in the first 30 minutes, and then follows a slow decrease about 6 hours, within 6 hours of initial impact. But after the concussion, the metabolic stress shifts neurons to a anabolic environment due to the lack of oxygen and lactate, as we've heard about before, accumulation. And this hypometabolic state persists about 5 to 10 days following this impact. Your cerebral blood flow following a concussion can fluctuate in 3 phases: hypotension or low blood pressure, hypertension or increased blood pressure or blood flow, and vasospasms, which is like just occlusion to your blood vessels at all. It won't be too bad. It's too bad for you. The metabolic changes have been suggested in multiple investigations to increase an individual's risk of a second impact syndrome, which is when a second concussion occurs within 24 hours, with a 24-hour state of vulnerability, usually during this hypometabolic state, which can present itself with cerebral swelling and high mortality risk. The next slide is we'll get into the CBD. What is CBD specifically? CBD, as I've alluded to, is a plant-based compound derived from the cannabis sativa plant, or just cannabis plant. It is known for the non-psychoactive component of cannabis, and largely therapeutic effects, and have been shown to inhibit the psychoactive effects of THC at high doses, and prolong the therapeutic effects by inhibiting the FAH activity and the adenine uptake. CBD predominantly interacts with the CB2 receptor, as we'll talk about later, of the endocannabinoid system, a receptor that is largely expressed in the PNS, or peripheral nervous system, and the immune cells of the central nervous system, or microglia. So, here's I like this slide. This slide's awesome. The endocannabinoid system, as pictured up here, is a system of two receptors, mainly two receptors, the cannabinoids receptor 1 and cannabinoids receptor 2. The two main endocannabinoid systems, which just means something that is made inside your body, is adenine and 2-AG. The actual name of it is too long, I can't say it. The primary function of the ECS is to maintain homeostasis. It also interacts with many different systems, as you can see up there. THC and CBD function like the endocannabinoids adenine and 2-AG. The endogenous compounds they are produced in response to exercise. And one study that I looked at previously said that they were involved in what is considered the runner's high, or euphoria, following the completion of exercise. This chart here just describes or depicts the non-CBD receptors and the concussion treatment, and their effect on that. So in addition to the CBD receptors, the ECS interacts with other receptor groups, and Singh in nearly 2020 charted at least five different, I'm sure there's more, that interact with the ECS and their influence on the concussion pathology. The TRPV1 receptors have been shown to reduce inflammation-induced pain in mice after a CBD dose of 10 milligrams. Serotonin receptors, or the 5-HT2A1 receptor, have shown anti-inflammatory properties, in addition to reducing exocytoxicity. Exocytoxicity and oxidative stress, and improved blood flow. PPAR gamma receptors regulate the metabolic and homeostatic disturbances, and have been shown to prevent the increase in brain-blood barrier permeability, as you've seen in the other diagram, in human endothelium and astrocytes, which is the cell that makes up the brain-blood barrier. And the adenosine receptors, A2A receptors up there, exhibit anti-inflammatory properties and reduce glutamate. And I forget that my original study talking about the second injury phase. The most important thing you could talk about for that phase is the glutamate, the increase in glutamate, and the connection of that with calcium, because calcium and glutamate are connected. Calcium is increased, which promotes the release of glutamate, and glutamate binds to a receptor called NDMA receptor. I can't remember the name right now, the specific name, but that initiates a positive feedback loop, which then promotes more glutamate release and leads to exocyte toxicity, as described here. I missed that. I should have said that earlier, but I didn't. So this is a therapeutic. This is the therapeutic potential of CBD. So rodent models indicate that CBD can mitigate several reactions following a concussion, because they reduce exocytotoxicity via the TRP1, PV1, and adenosine receptors, in addition to the release of endocannabinoids. The serotonin receptors and the PPAR gamma receptors modulate the energy crisis, and the cerebral vascular changes, which Sigoni, Gori et al. 2011 and Chang et al. 2012 considered as the main biological explanation behind the concussion symptoms, because the mitochondrial dysfunction following a concussion causes exocytotoxicity, oxidative stress, damaging your neurons, and leading to an expression of symptoms and increased vulnerability of a second concussion. Now we get to the fun part. It is the fun part for me. So modern or contemporary mixed martial arts, or MMA, began in November of 1993 with the establishment of the Ultimate Fighting Championship, or UFC. Now, it is important to understand that the UFC, as many people think, that is that is the only organization that exists, but it is not the case. It is not the end-all be-all when it comes to professional mixed martial arts. MMA is the sport of which there are several organizations that promote it. The UFC happens to be the most well-known organization, and with this popularity, the need for improved safety is increased. So for the CBD use in mixed martial arts, we've now have established that in combat sports such as MMA and boxing, a concussion will occur at some point during an athlete's career. Regardless, the word is not there. So the need for a safe treatment, safe concussion treatment remains. Recently, cannabis substances were removed from the prohibited list from the U.S. Anti-Doping Association, or USADA, in January of 2020. Prior to that, the drug policy of the UFC amended their definition, what's considered in competition. This amendment is known as the Nate Diaz rule. Nate Diaz is an athlete under the UFC banner. After he was seen vaping CBD at the UFC 202 press conference, as he at that time he was considered in competition, and he was considered to be consuming a prohibited substance at that time of 2016. And they amended their in competition definition. So when you leave the medical tent following the competition or your fight, you are not considered in competition anymore. So in May of 2021, along with this 484-page document, the UFC Performance Institute, which is a huge facility in Vegas, released its official 5-stage concussion protocol for its athletes. And I will just focus on stage 1, but you can look at the other stages as well. Stage 1 is the initial recovery phase, which suggests to not engage in any cognitively demanding activities for a brief period, and only take Tylenol for pain management, which I don't know how that works, but it could work. Based on the research results, CBD shows beneficial effects in mitigating the symptoms of concussions. Therefore, it may benefit the athletes to begin CBD treatments in their careers to reduce the severity of concussions and improve their quality of life during and after their careers. Also, the UFC PI, as it's called, may want to consider CBD as an option for pain management treatment, in addition to Tylenol in the recovery phase and throughout the training camp and practice. Right now, the NFL and the UFC recently awarded funds to current and prospective studies on cannabis and injury prevention. The UFC has added funds to what's called the Professional Athlete Brain Health Study, which was formerly known as the Professional Fighters Brain Health Study, but now it includes like bull riders and stuff. It's a longitudinal study focused on identifying biomarkers for TBI and CBD, CTE in vitro or in living subjects. The NFL added funds to one study that examining CBD in post-competition soft injuries, and the other study on the effects of cannabis on pain management and neural inflammation. The latter study could provide further evidence for the UFC to add CBD as a pain management option for its fighters. And last but not, second to last, if we have time, last but not least is the shortcomings that the research has shown. Most research consists of animal models with mice, rats, or piglets. Few studies have examined humans. Those that the one that I can remember just focused on brain activity, not necessarily concussions, because that seems unethical. But the one that did use human-like substance is like the human cell cultures to explain non-CBD receptor effects. And studies need to have more randomized control trials, and to solidify these therapeutic effects, and research needs to identify if any sensitive populations do exist. Now, I do have examples if I have time. Do we have time? What time is it? I don't know what time it is. Does anybody want to see the examples?
Play 'em.
Okay. I love it. I am a huge fan. Do they play? Oh, you said it. Oh, no.
Lucas, this is the match that I won, right?
Hey, I don't know. We'll have to exit out for a minute. I can play them, but I don't know if they play. Can I exit out? Oh, you know what? They didn't edit. Click edit. Yeah. You know what? Enable content. No one has did this. Who did do that? Okay, let's have some fun now. I'll blow it up. Someone said blow it up. I'll blow it up. This is too much fun. I will have fun. This is why it's so entertaining, but this is why you need help. It's so good. I love it. It's great. Oh, that's great. Don't. Now, this one, I kind of feel bad for the lady, and you'll see why in a second, but I feel bad for her. I really do. It's so bad. It's so bad. It's so devastating. So bad. But good. So bad. But deadly. It's so bad, but yet so good. Yes, there it is. So that's my presentation. Any questions? She got knocked out. She didn't get rocked.
Lucas,
She's
I
okay,
wanna
though.
start
Yes, go ahead.
because I'm so interested in CBD.
Yes.
And I'm very high on that presentation. I got two key questions.
Yes.
These are big questions because I'm familiar with this field and it
Yeah.
come up so much. Did you read the difference between, or hear people talk about the difference between psychoactive versus something that is intoxicating?
No, I don't know the difference. I would consider, in terms of the endocannabinoid system, I would think that they would interact with the same receptor, which is a CB1 receptor. But in terms of the effects of difference between intoxication and psychoactiveness or psychoactivation, I don't know the total differences, but I'm sure there's similarities and differences to anything.
Because a lot of people will say, like, oh, it's not psychoactive as well. It is psychoactive. It
Yeah.
interacts with the brain. By definition, that's psychoactive.
Yeah.
So it's a big thing, like, you know, when you hear experts talk about it, it's that, it's like anything else. The definition has
So
to be set in
it-
stone.
so it'd be-
right? It's non-intoxicating,
Yeah.
meaning it doesn't typically give people a euphoric effect.
Yeah.
Right? So that's a big clarification. Here's my big question.
Yeah.
CBD,
Mhm.
untested, it's murky waters right now, both in the trenches when you try
Uh-huh.
to purchase it and when you
Yeah.
start to look at some of the research. Somebody comes to you, Lucas.
Yeah.
You're an exercise fitness
Yeah, yeah.
professional, and they say, I want to take CBD, where do I start? What do I need to watch out for? What are some of the quick bullet points that you have in your chamber to kind of direct that conversation?
I would consider start with a low dose and then go up from there and see how you feel. I did watch in the end of my research. I did watch. You have to watch out for some gut, like the effects on gut health and stuff like that. I know it can be beneficial to an extent. I think high doses can cause what's called leaky gut syndrome. So I would think just to pay attention to that. And if someone came to me to say that, I'd start low and see how you feel and go from there.
Yeah, I agree with everything you said, Lucas. Dosing CBD is very challenging
Yeah.
in certain ways. Like if you look at the
Yeah.
literature on CBD, they're using hundreds of milligrams of dosing.
Yeah.
Yet you go to a dispensary or somebody that's selling CBD, and the average dose is probably somewhere between 30 and 80 milligrams per day. So
Yeah.
the vast difference, that's what makes it really murky.
Yeah.
However, like just for people in this room as well, like there are cautions that
Yeah.
you have to watch out for at CBD. Number one, hemp is a natural detoxifier.
Yeah.
It pulls out whatever's in that soil. If this hemp that
Oh, I
your
didn't know
CBD
that.
is coming from is grown in poor soil, it's very, very problematic, right? And right now,
Oh, yeah.
CBD
Okay.
is kind of like a supplement. So
Yeah.
there's really no oversight of what's going on. So you have to get products that are third-party tested, that have some, independent lab there.
Mhm.
They're grown in good soil, no heavy metals, blah, blah, blah.
Yeah.
In 2017, you like that, Naomi? In 2017, the American Medical Association did a really big study on CBD. They found that 70%, it's a good study, well done,
Yeah.
70% of products were completely mislabeled, meaning some had 0 CBD,
Yeah.
some had 3 times the amount of CBD, but mislabeled.
Yeah.
And, one of the problems, the last thing I'll say before I stop talking,
Mhm.
here's the big issue. The average person that hears about CBD, maybe on social media or some, television
Yeah.
show, they go online, the first place people go to shop for something is Amazon.
Yeah.
You go on Amazon, you type in CBD, most often what you're going to get is hemp seed oil. People are purchasing hemp seed oil thinking that it's CBD. Hemp seed oil is so minimal in cannabinoids, it's almost
Yeah.
no CBD.
Yeah.
It's still beneficial, it has essential fatty acids to it,
Yep.
great, but it's not CBD. And that's where a lot of CBD gets a bad rap because people they don't even know they're not even taking it.
See.
Those are key points. Good job, Lucas. You knocked it out of the park.
Thank you.
What are you going to do? ZZ Top's sharp, dress.
Yeah, I should have that song playing. And I thought of it, but I didn't have it. Any more questions? Yeah. Yeah. Yes.
Because you know me, I cannot wrap my head around this sport.
Yeah, I know.
Because you tried to talk me into it how
That,
many times?
I don't know.
I said, I just can't get excited about
But
going to get punched in the face.
I know, but that's.
I'm just saying I'm going to miss our conversation.
I know.
It was definitely fun to learn about. And you know what? You know what the amazing part is?
What's that?
You could give certain athletes all of the data you just gave them. The PPE data,
Yep.
the concussion data, the no teeth data,
Yep.
everything that would happen. And people still will be like, you know what? Sign me up. I can't wait to go get punched.
Yeah, though it does take a different person.
You know, I would love to get into the psychology, but part of me does not want to at the same time. You know what I mean?
Yeah.
So, but anyway, I do love that you love this so much. That was my comment, but I'm just gonna miss our comment.
Okay. Yeah. Yes. Thank you. Yes, Dad.
Question, with the five percent tap on
Yes. What?
what happened?
Yes, he was. Ask him yourself, man.
Well, Ted Congo got up, so I don't know if it's concussed or not.
Well, he probably was, but not as much as Pat was.
By the way, did you bring us any samples?
No, I didn't have it. I'm sure. I'm sure if I could get one from the dispensary up the road, I could, hand them out, but I didn't. Yeah, I could do that.
Lucas,
Yes.
can you just, in a couple of sentences, connect the benefits of CBD to the reduction in the concussion symptoms? Because
Yeah.
you talked about all these receptors and all that kind of stuff. So
Yeah.
Can you just sort of briefly summarize it?
So essentially, that's CBD helps with the immune response to neuroinflammation. So it reduces your inflammation. It can reduce your metabolic fluctuations, and therefore, it could. Since the metabolic fluctuations are known as the main biological explanation for the symptoms, it could indirectly reduce the signs and symptoms of concussion through that.
Sorry, I know that was a wet-blanket question.
No, you're good.
Okay, thanks.
You're good. Any other questions? Wow. Thank you.
Wait, one more. Spell CBD.
Oh God. Here, I can do you one better. Where can I find it?
Oh, there it goes. You want to find it?
There it is.
There we go.
CBD. That's how you spell it right there. It's CBD.
All right, everyone. Well, first and foremost, I think we should all give one more round of applause to all of our seniors. That concludes today. Thanks, Lucas.
You're welcome. Thank you.
That concludes our senior symposium today. If you have not signed in, Tracy had a sign-in list. You will get all a PDP for obviously coming. So if you signed in, we'll type up your name and make sure you got one. We'll put it up front with Tracy. So make sure you guys collect that. We'll file all of that. Thank you for attending today. Hopefully you're getting a little excited too for when you become a senior, you get to do this all up here, or you're like, oh my God, I don't want to do this at this point. Don't worry, you'll survive. You did a wonderful job. Last thing, before you guys get going, feel free to grab more food and bring it on the way out, because I don't want to bring it all home and I don't know what to do with it. So make sure you grab some plates on the way home, get what you want, and so forth. Seniors, hang for a little minute. We got a gift for you, and I want one more picture of you guys up here and so forth. That's it. Have a great evening, everyone, and